Welcome, everyone. Thank you for joining us for today's webinar, Why Pain Control is Good Science, the Scientific Rationale. It is presented by Marcel, Perret-Gentil, DVM, University Veterinarian and Director at the Laboratory Animal Resources Center at the University of Texas at San Antonio. My name is Judy O'Rourke, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box. Our speaker will respond to your questions via email following the presentation. If you have trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know that you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Now, without further ado, please join me in welcoming Dr. Perret-Gentil. I will now turn the presentation over to him.
Well, thank you, Judy, for that introduction, and let's get started. So today, the goal of this presentation will be very simple. We'll discuss about the indirect effect of pain on experimental results, and we'll give you some practical suggestions for the minimization of both physical and mental pain, which both are very intricately connected to each other. So in 1655, Edmund O'Meara said that the wretched torture of vivisection places the body in an unnatural state. Basically, what Dr. O'Meara, Mr. O'Meara, stated was that the physiology of the animal could be affected by pain, which eventually will translate the results into unreliable data. Let's see how true that is. So what is biomedical science? Biomedical science is seeking to eliminate all potential variables. So an investigator could focus on the objective of the study, whether that be a behavior, compound, a molecule, or an injury, with the goal of obtaining consistent data and eventually a reliable publication, which is the outcome of the vast majority of all research that is done anywhere in the world. So pain, along with stress, will stimulate the HPA, which stands for the hypothalamic pituitary adrenal axis, which also stimulates the sympathetic nervous system. And these two will induce a release of glucocorticosteroids and catecholamines, which will eventually affect behavior of the animal, autonomic nervous system, the neuroendocrine system, and the immune system. And when these systems, beginning with pain and stress, which puts into motion this cascade, will eventually result in variables in the data. So this right here, the word data, all in black, is what the investigator is looking for. The investigator is looking for pure, unaltered, uniform data. But what happens is that variables will make data just mixed, basically. Every variable will affect, really, if you want to put it this way, the color of data and the outcome of data. So what are variables? What are we talking about? We're talking about poorly controlled environments or surgical procedures, surgery that is contaminated, practices that are not consistent in the animal facility. For example, lack of solid SOPs where things are not done the same way all the time, the presence of pathogens in the colony, the lack of certified diets, and poor microenvironment. And of course, we know that analgesics can affect data. The thing is that pain, and of course stress too, can affect data. So ideally, this is what the investigator is looking for. An investigator will love to eliminate every single bit of variables. But the reality is that not every single variable can be eliminated, but variables can be minimized by doing things right. So we can focus on the objective, and we have data that is perhaps 95% confidence that it is reliable. What's unacceptable is that mixed data that is influenced strongly by variables. That is totally unacceptable. So what about treating pain or not? So it is very frequent, and I'm the first that reads the protocols of my institution and other institutions that I've worked with and institutions that I still work with. And very not uncommonly, an investigator that is concerned about the use of analgesics will say, we can't use analgesics. And then quotes the name of science, and they don't say exactly the words in the name of science, but the justification they give all kinds of literature citations indicating, wow, this pathway and that pathway and this interleukin and this inflammatory response and this and that and the other will be affected by the analgesics that I use, that I intend to use. So I don't want to use analgesics, and our IACUCs and our veterinarians say, okay, that's justified, so let's not use analgesics in this protocol. And then the animals will end up having pain. So, but which one of these, which has the greatest impact on data? Is it the analgesics or is it pain? Let's look at it for a little bit, okay? So analgesics, we know that they can affect the immune system and the experimental results. There's no doubt about it. No one, and I'm not arguing that at all here in this presentation, but what I can tell you is that pain results in a cascade of physiological, immunological, cognitive, and behavioral effects that may make uncontrolled pain a source of experimental results. That is a fact, and we cannot deny it. So what will pain do to the animal, to the physiology, to the well-being of the animal? So pain will affect the sympathetic nervous system, will affect the coronaries, will affect cardiac output, will affect the myocardium. It will increase systemic vascular resistance, blood pressure, oxygen demand, spleen ischemia. I can go on and on. It will affect the kidneys, will increase aldosterone, sodium and water retention. It will induce the secretion of endogenous glucocorticoids, leading to immunosuppression and delayed healing. It will affect metastasis, leads to self-mutilation, the animal will stop grooming, and anorexia. And eventually weight loss, and the animal will be in a catabolic state. The animal will have an increased coagulation rate, blood viscosity, increased platelet aggregation, interference with normal activities, and we could keep going on and on. But the one that I like to focus on is the altered mental state, the anxiety that the animal feels, the stress of the animal, which will lead to hyperalgesia. So what is hyperalgesia? I have it defined here, but let me explain. Hyperalgesia is say that a typical pain insult will result in from 1 to 10 and let's say 4.5 on a scale of 10, or 4 in the scale of 10 pain level. Well, hyperalgesia is basically a pain that is greater than that which is expected. In other words, this animal, instead of having pain level 4, will probably have pain level 6 or 7. It is the amplification of the pain signal. So anxiety, stress have the potential to induce in hyperalgesia, which is really contrary to good sound practices, correct? So this animal right here, what contribution will this animal have to the experimental results? This animal had a surgery in the femur. This animal's not doing well. And, you know, it's really has become, this animal has become a worthless animal, has to be euthanized. So if Edmund O'Meara in 1655 said that the animal physiology could be affected by pain, which could result into unreliable data, if he could say that back in 1655 with almost no basis, almost, I said almost, I didn't say no basis, but almost no basis, because when you compare to the data that he had then to what we have today, wow, today we have plenty, we have an enormous amount of literature that show that the pain can affect the animal's physiology and therefore the experimental results. So typically your investigator, the one who justifies in the protocol, who says that, no, I can't use analgesics because it will affect pathway A, B, C, or D. And this is how the investigator would like to see, or the investigator views the use of analgesics. As the analgesic dose increases, so do variables. However, this is the veterinarian's view. This is how I like to see it. This is how I would like to see all pain-induced research, is that as the analgesic dose goes up, but the variables will go down eventually. But what is the right view? Is it the investigators or is it the veterinarian? Well, I don't know. Is it here? Is it here? 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 I don't know. But what I'd like to do today, and one of my goals of this presentation, is not to give you an answer and tell you, you must give analgesics. You must have strong pain control in every experiment, because I don't know. I don't know your science. I'm not, I'm just a veterinarian, Labano veterinarian, who really wants to stick up for the animals as much as possible. But we know that giving pain control should be considered, not just dismiss it. IACUCs, I want to encourage our IACUCs not to just take the investigator's argument that, well, the investigator gave a series of citations indicating how the analgesics will affect his research, with that given thought to the fact that, and we saw about 3 slides earlier that really show and pretty much give evidence that pain itself can affect many of those same pathways that the analgesics will affect. So having said that, having given you an argument, at least some food for thought on the control of pain, I believe that I think we no longer, veterinarians and IACUCs, need to sit just still and take the investigator's word, even when the investigator gives strong citations, that analgesics need to be discounted. I think we need to really reconsider our approach to pain control. Again, realizing that pain may, in many cases, and I would almost like to say, but I can't prove it, that in the majority of the cases, and of course that is depending on the degree of pain and the chronicity of pain, is that pain could affect just about most research, even though the investigator had given pretty strong evidence from the literature that the use of analgesics could be counterproductive to the research, his or her research. So let's talk a little bit about an approach, a practical approach to pain management. These are my experiences, and I like to share it with the audience. One is that pain is both physical and mental. Even though they're two separate topics, they're inseparable. We spoke earlier, we mentioned earlier the concept of hypertherapy, that when an animal is under mental distress or stress, hyperalgesia is more likely to happen and induce more physical pain. So let's talk about, very briefly, about pharmacological methods of pain control. This is part suggestion, part philosophy, but I want to show that what has worked for me and for your consideration. So there's some principles I'd like to hone on. One is preemptive versus post-op approach to analgesia. So if, you all remember the controversy last year, the year before, where North Korea was threatening the United States, and the United States was reactive in words and concerned that maybe there was a threat that maybe some missiles could be launched from North Korea all the way to and reach some major cities in the United States, let's say San Francisco. So let's say that North Korea sends that missile hits and kills 500,000 people in the city of San Francisco. Well, if I'm the president of the United States and I know that a missile is coming and I know that I can prevent it, I'm going to be the first one to launch my missiles against that country. So if I'm the president, then if I know they're coming, I'm going to shoot them in the air, or I'm going to just go after that nation that is being the aggressor against my nation. And that is a preemptive attack. And that if I let that missile hit San Francisco, the losses will be great already. So that's the concept of preemptive analgesia. We believe, or I believe, that hitting the enemy before the enemy hits you is a good concept when it comes to analgesics. In other words, if I'm an investigator, I'm waiting until the animals recover from analgesia, and the animal's already in pain, and give a post-op analgesics, that analgesia is not going to work as well as if I would have given this before the insult, in other words, preoperatively. So that is a concept of preemptive analgesia. A multimodal approach versus a single analgesic is superior as well. So let me use the scenario of the missiles and war between two countries. So if I'm the United States and I know that I'm fighting against another country, I'm not promoting war. I'm just giving you examples and illustrations, and is that I'm going to attack it from every direction that I can. I'm going to go through land. I'm going to go through air. I'm going to go through the sea, and I'm going to hit the enemy from the front, from the rear, and from the side, from top. That's a multimodal approach to go after the enemy versus a single attack, just land approach. So analgesia, the combination of analgesics, works significantly better when we think of a multimodal approach. In this case, combinations typically of nonsteroidal anti-inflammatory drugs with opioids, and in combination with local or regional anesthesia, work wonderful because pain is induced through many pathways. And as we're going to discuss in just a few minutes, the nonpharmacological method is key to treat mental pain. So another concept that we need to keep is that, let's say buprenorphine is given hour zero, and the levels of pain control go up and then go down. And so when the pain goes down, say every 12 hours, and when pain is at the highest, then we'll just give another dose. We go We give it every 12 hours, up and down, up and down, up and down. But what if we consider overlapping doses to avoid those peaks and valleys? And now in the United States, I know that in many other countries, in fact, I don't even know if we can find this in other countries, SR formulations, the sustained release formulations, have worked really well. I'm using them at my institution because what these do is that they provide pain control when it's given immediately soon after it is administered. The levels go up and they are maintained for approximately 72 hours. And the two most common drugs that are being used in lab animal, in particular in the United States, is meloxicam SR and buprenorphine SR. So the concept of avoiding peaks and valleys is a valid one by doing continuous or overlapping regimes, as we discussed in the graph. And these sustained release formulations, I'm sorry if they're not, you can't find these in other countries, but I understand that Zoofarm is a companion pharmacy that produces these SR formulations are not in other countries. Hopefully they will, because there's a market. And I'm pretty much at this point, I am treating all our animals here at UTSA using this concept of the SR formulation. So let's discuss, remember we spoke about non-steroidal anti-inflammatories, we spoke about opioids, and then local anesthesia. Let's talk about local anesthesia. One of the advantages of the local anesthesia is that it can reduce the required dose, overall dose of the systemic analgesics. So let's say that in my analgesic multimodal approach, I give NSAIDs and I give opioids. Well, we know that every drug has its ill effects, so side effects. If I use local anesthesia, I might be able to even lower the dose and therefore the side effects of each one of those. And in fact, anesthesia too. If I'm using, let's say, isoflurane, and you know, isoflurane is one of the better anesthetics that are out there. However, it's not without side effects and issues. And if I give the local anesthetic, maybe if I typically keep my animals for this particular procedure 2.5% isoflurane, well, maybe now I'm going to keep it more like a 2%. And local anesthesia also minimizes the hyperalgesia, again, which is an amplification of the pain signal. This is the concept that I use when I recommend to our investigators the use of local anesthesia. I tell them to do an infusion of a combination of both lidocaine and bupivacaine. The lidocaine, one will say, okay, well, the animals are not gonna need it because the animals this lidocaine doesn't last long. They say for about 40 minutes. The thing is that the use of lidocaine will help that concept that I just mentioned, that maybe you can keep that analgesia instead of a 2.5, maybe 2%. I don't know, something like that. And lidocaine, although it doesn't work right away, it takes quite a few minutes to start working. It lasts for quite a few hours. And it is, in particular, this immediate post-op, and in all species, but in particular rodents, that immediate post-op is really crucial, because that is, if an animal wakes up with pain, and that animal is less likely to drink and to eat. And it is that time when the catabolic state is really, the body is really going downhill the quickest, and we want to revert that. The use of local anesthetics has the power, it influences the animal, or it minimizes or brings down the pain sensation in the surgical area, so that the animal post-op can start feeding and reversing the catabolism. Now let's focus a little bit on the non-pharmacological methods of pain control. So I'm gonna ask the audience, and And of course, you won't be able to answer because I'm the only one that can talk here. But I'm going to ask anyway, how many of you have ever had a really severe headache, like a migraine, or just a plain old, very painful, whatever, let's say a headache? I think, if I could see your hands, I'm pretty sure that I'm going to see just about every hand raised. And so if you've had a migraine or a really, really severe headache, what do you do in addition to that wonderful miracle pill, that medicine that you take? What do? Well, you want to go lay down. You want to turn the lights down. You tell the wife, tell the kids to shut up. And dogs, I'll take him outside so I don't hear him. You want the temperature to be just right, and you want to feel very comfortable. So what did we just describe? We just described the non-pharmacological method of pain control. So does it work? Yeah, you bet it does. It does work. And you have experienced it too. And you have applied the non-pharmacological methods of pain control to your own well-being. But when these protocols are written, how are they written? They're written in a way that the investigator only describes analgesics. But where is the description of non-pharmacological methods for pain control? So let's think about that. How do we do this? How do we what methods that are non-drug can we help the animal? One is aseptic technique is essential for pain. Later, I will give you a link to very easy, a link to our website, the Lab Animal Resources Center, where we have developed a series of videos to help the investigator apply aseptic technique in ways that are very, very simple to do. So why aseptic technique? I wish I had time to really go over real details, but it is well documented that the infection will lead to clinical and subclinical. Subclinical means even though you, as an investigator, you may not see the signs, the overt signs of infection, there is something underneath that incision that is subclinical. It is an infection, because it contributes to the inflammatory process. The inflammation leads to pain. Pain leads to physiological changes that we've seen earlier in this presentation. And guess what? We have variables. So fear and anxiety, they enhance the pain response. As we mentioned earlier, providing a stress-free environment must be included in the pain management program. And I think it should be discussed in protocols. We ICOPs need to be asking investigators, what are you going to do to minimize pain? So I'll give you a couple of suggestions here. A few suggestions, you can develop your own list. But we know that minimizing the environmental stress will minimize stress-induced hyperalgesia, as discussed earlier. So let me give you examples. So you see this one in the middle, that's called EnviroDry. I'm a new veterinarian in Texas Tech University, and I had to travel once a week to a facility that was about an hour's flight away from the headquarters. Texas Tech University, the headquarters was the Health Science Center was in Lubbock, Texas. So I had to fly to El Paso, Texas, to the Texas Tech University Health Science Center, El Paso. So I'm a fairly new veterinarian, lab animal veterinarian. This was maybe about 14 years ago. And I'm doing my rounds, and I trying to learn the program, and then I go into this room full of rats, and I see rats that they were Zucker rats, diabetic rats, obese, that had been implanted into the abdominal aorta. They had an implant to measure blood pressure. And the blood pressure was measured without wires coming out of the animal. It was just done remotely. But I go look at these animals that are individually housed. Obviously, they had to be individually housed because they had to measure blood pressure individually of each one of the animals. So there was a plate under each cage that measured the blood pressure of each animal. But there was nothing but bedding, corn-cob bedding. So I go to the investigator's lab and go meet him. Hello, Dr. Such and Such. Nice to meet you. I'm Marcel, the new veterinarian. Oh, yes. You know, once we're done with all the pleasantries, I asked the doctor, I noticed that your cages are barren. Would you mind if we put some EnviroDry? Because enrichment really helps animals display their species-specific behavior. And you know, rats like to hide, you know, get in dark places and things like that. He said, oh, sure, Marcel, there's no problem at all. His name was Daniel, and I'm not going to say his last name just in case. But by the way, he was very compliant, very cooperative, and great individual too. And so from that point on, we put EnviroDry into the cages. Well, a few months go by and I run into Daniel in the hallway, and he's talking. He said, Marcel, I got to talk to you. I said, oh, sure. How are you? What's going on? Marcel, ever since we implemented the EnviroDry into the rat cages, the mean blood pressure has dropped between 10 and 20 points. I said, Marcel, my data has improved unbelievably well. Wow, that's great, Daniel. I'm so happy to hear that. So as a result of that, we did a poster and we sent it at one of the meetings, and that's a great story, I think. Let me give you one more story. This little hut right there, the red hut, you know that mice and rats can't see through the red spectrum. And so a few years ago, I sent an email to all our investigators that are breeding animals. And I tell them, investigators from this, starting on such and such a date, we're going to place these huts facing the front of the cage. And all breeders, all breeding cages. And nobody objected, sure, you know, additional enrichment. So a few months go by, and then I get an email from one of the investigators, and the investigator tells me, Marcel, this has worked really well for us, because ever since before we implemented the huts, my rats were producing about 6 pups per birth. Now, after the red huts, now they're doubling that. So I said, wow, that's a really good success. So what happens? What did we do for these animals? We enrich the environment. We diminish the stress, because now they were not as bored. The mice and the rats that had the red hut, perhaps they were not able to see the personnel, the monsters that were working in front of the cages and scaring them. So perhaps the embryos were not being reabsorbed. And so to minimize environmental stress really does work. Although the red huts scenario has nothing to do with pain, it is also applicable because it really brought down the environmental stress of these animals. So what about tasty calories? So we have used routinely these diet gels and also these bacon softies that are very delicious to our rodents. And they are full of energy. And remember we talked about earlier about the rats and the mice that wake up from surgery and then they need to eat right away. We talked about the local anesthesia as a way to really help them eat right away. Well, it does work, but also if we can just give them very tasty calories, then the animals are more likely to eat them. I give you a couple of examples where I was doing these femoral implants. We took about half a centimeter of the femur and we put implants, we put bone plates, and that's a very painful procedure. Of course, we cover them with good systemic, local and systemic analgesics, but nonetheless, the animals were going to wake up in a fair amount of pain. While these rats like this diet gel so much that the animals were still recumbent, unable to stand up, All they could do was just to move their heads a little bit, and they were just lapping the diet gel, even while the animals were semi-conscious. So there is a company that I work for. It's called, well, I'm not going to say the name, but so this company, we have animals that are under chemo and they have tumors induced. And you know what happens with cancer? The patient stops eating, they become really skinny. And in the case of lab animal, the protocol calls for endpoints. So the animals were really losing a lot of weight, and they were reaching their endpoints because of the weight loss, about 30% of the weight loss, and we have to euthanize them. Well, what did we do? We started putting these bacon softies at the bottom of the cages. These animals that had refused to eat because of either the chemo or the cancer, now they wanted to eat, and they started to gain weight. And then these animals, instead of being lost, and that data being lost to euthanasia, to the endpoints, now we were able to obtain data from these animals. What about social housing? Social housing is crucial because the norm, and I've seen so many protocols that the investigator will say, no, we can't use, we have to house the animals individually because they're going to pick on each other's sutures. Well, my approach now is, do you have evidence? But we know we have evidence that rats and mice that are housed like rats or with a spinal cord injury recover much better when they were group housed and when they were individually housed. And mice with telemetric implants, when they were housed socially, they recover better. So social housing, even post-op, is a non-pharmacological method of pain control. And animals recover better when they're housed together post-op. So yeah, the investigator will tell me, yeah, but I've seen them pick at each other's sutures. Well, how many animals have you done? Well, I've done hundreds of these surgeries. How many times have you seen this happen? One or twice? Well, even in that case, I think we, as an ICO, we need to challenge investigators. Say, well, what about for the sake of all those other hundreds? Implement the social housing, even at the risk of maybe the one or two or the three that may pick at each other's sutures. Something to think about. What are other non-pharmacological methods of pain control? One is habituation to procedures. The dim lights, remember when you have a headache, the dimming the lights in the room, really good for you. The same way with lowering noise, you did not want to hear the dog, you didn't want to hear the kids scream. And a lot of people have, these wads of keys and these metal cage card holders. Sometimes they fall to the floor in the animal holding room, and they cause stress, and people are talking loud. I think when we work in the animal holding rooms, we should really minimize or at least lower our voices. Pre-op fluids are crucial. We have seen, in fact, we require of our investigators pre-op that all mice and rats are given fluid therapy, and that decreases and has decreased morbidity and mortality, that is a method that will really save and really improve the recovery of many, many, many animals. Thermal support, hypothermia has a tremendous negative impact on the animal, and acclimation is crucial as well. So why acclimation? Why do we need to implement acclimation? Well, if you place an order for your mice, let's say Charles River, what does Charles River do? They receive the order, they go into the animal holding room. These animals have been housed all their lives in this particular cage with this particular bedding. The technician goes and picks a few of the animals that were ordered, and they put them in this cardboard box, filtered. It's a new kind of box, new kind of way of feeding, different lights and all that. They place the animals, then carried. They're taken into a truck. the truck is a diesel truck and it's vibrating and the smell. And then next day, they're going to travel all night or a couple nights. And then they get to the new facility and they hear different voices, somebody talking about the weather in the hallway. Then they're placed, the animals are placed in the animal holding room, new lights, new everything, new food, new sounds, new experiences, new smells, new cage, new bedding. I think this animal, by the time this animal arrives to the institution, this animal is mighty unhappy and mighty stressed. Is this the animal that I want to use for my experiments? I don't think so. That's why acclimation is key. And different institutions have different days of acclimation. Some have 72 hours, some will have a week, some will have longer than that. But some sort of acclimation to the new environment is key before the experiments are implemented. And of course, this is what we want to start with, this happy animal that is as stress-free as possible, that is really ready to undergo experimental procedure. So in summary, we must consider the indirect effect of pain on experimental results and not just take the investigator's word, even literature citation, to really prove his or her point that analgesics cannot be used. And we must address both the physical and the mental pain. So this is it for this presentation. And here's a website that I'm going to leave it here for if you want to see. We have a lot of resources, a lot of materials that a lot of people are using throughout the world. And in particular for surgery, we have a number of surgical procedures detailed in here. And in particular, the aseptic surgery that has been so difficult for investigators to implement. We have implemented here. We have a series of videos to really make aseptic technique a lot easier to do. Plus, we have handouts on breeding, diagnostic sheets on if you're having breeding problems, et cetera, biomethodology and all that. So that concludes my presentation, and I thank you for attending. And I hope I can meet some of you someday in the near future.
Thank you, Dr. Perret-Gentil, for that informative presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that this webcast will be available for on-demand viewing through May 27th, 2019. As a final reminder, our speaker will follow up with any questions you've submitted via email. That's all for now. Thank you for joining us, and we will see you next time. Bye.